Hydrocephalus is a condition characterized by accumulation of excessive cerebrospinal fluid within the central nervous system. It may occur due to a disturbance in the flow of CSF, defective absorption, or increased production of the cerebrospinal fluid. Before starting the discussion on hydrocephalus itself, it is important to recall the basic anatomy of the ventricular system and the flow of cerebrospinal fluid. Cerebrospinal fluid is mainly produced by the choroid plexus of the lateral and fourth ventricles of the brain. Normal CSF production is about 0.2 to 0.35 milliliters per minute, and the normal circulating volume of CSF is 120 milliliters. CSF produced in the lateral ventricles drain into the third ventricle through the interventricular foramen. Third and fourth ventricles are connected to each other via the cerebral aqueduct, located in the midbrain. CSF in the third ventricle drains into the fourth ventricle and then into the subarachnoid space through the foramen of Luschka and the foramen of Magendie. Most inferior part of the fourth ventricle continues downwards as the central canal of the spinal cord, which is also filled with cerebrospinal fluid. CSF circulating in the subarachnoid space is absorbed into the dural venous sinuses through arachnoid granulations. If the production of cerebrospinal fluid is greater than its absorption, CSF tends to accumulate in the ventricles and in the subarachnoid space, which causes raised intracranial pressure. This imbalance between the production and absorption of CSF could be due to several reasons, including overproduction of cerebrospinal fluid, reduced CSF absorption, and increased pressure in the dural venous sinuses, which indirectly reduces CSF absorption. As CSF accumulates in the subarachnoid space, excess fluid is absorbed by the optic nerve roots, causing papilledema. Increased CSF volume leads to ventricular dilation, particularly the lateral ventricles. This causes several structural alterations in the brain, including elevation of the corpus callosum, stretching and perforation of the septum pellucidum, and thinning of the cerebral cortex. This MRI section demonstrates dilation of lateral and fourth ventricles and elevation of the corpus callosum due to increased CSF volume. Enlargement of third ventricle down to the pituitary fossa may cause pituitary dysfunction and put compression on the midbrain. Due to raised intracranial pressure, parts of the brain can get herniated, as you can see in this image, which shows herniation of the cerebellar tonsils through the foramen magnum. Signs and symptoms of hydrocephalus depend on several factors, including patient's age, underlying cause for hydrocephalus, location of the obstruction, and duration of the obstruction. Signs and symptoms of hydrocephalus in infants include head enlargement, reduced activity, poor feeding, and vomiting. Adults show reduced mental capacity, headache, neck pain, which suggests tonsillar herniation, vomiting, blurred vision due to papilledema, double vision due to sixth nerve palsy, drowsiness, limb spasticity, and lower limb weakness due to stretching of pyramidal and paraventricular tracts. 4 types of hydrocephalus have been identified: normal pressure hydrocephalus, communicating hydrocephalus, non-communicating hydrocephalus, and congenital hydrocephalus. Normal pressure hydrocephalus is a rare condition affecting the elderly population. Here, the ventricles get enlarged, however they usually have a normal intracranial pressure. There is no papilledema. Sometimes, intracranial pressure increases only at night. Normal pressure hydrocephalus is characterized by a classic triad of symptoms: gait apraxia, where the patient is unable to initiate walking movements, dementia, and incontinence, initially urinary, followed by fecal incontinence. Patients with normal pressure hydrocephalus also have exaggerated reflexes and a positive Baginski sign. Headache is not usually apparent in normal pressure hydrocephalus. The mechanism of normal pressure hydrocephalus is not fully understood. However, some theories suggest that there is a resistance to the CSF flow within the ventricles, which leads to raised intracranial pressure at night. Ultimately, this leads to stretching of the ventricular walls and enlargement of ventricles. In communicating hydrocephalus, there is a normal flow of CSF between the ventricles and the subarachnoid space. This condition typically occurs due to defective absorption of CSF into venous blood. Rarely, it can occur as a consequence of CSF overproduction. Major causes of communicating hydrocephalus include intracranial hemorrhage, meningitis, and brain tumors, which can damage arachnoid granulations and cause venous thrombosis, leading to venous drainage insufficiency and defective CSF absorption. Accumulation of CSF in the subarachnoid space leads to atrophy of surrounding brain tissue and deep white matter structures, and crowding of sulci, as you can see in this picture. Non-communicating hydrocephalus occurs when there is an obstruction to the flow of CSF within the ventricles or its outlets, like foramen of Luschka and Magendie. The most common cause of non-communicating hydrocephalus is mass-occupying lesions within the brain, which disrupt the ventricular anatomy, leading to CSF accumulation and enlargement of the ventricles. Congenital hydrocephalus is referred to as dilation of ventricles during fetal life or infancy. Causes include obstruction of cerebral aqueduct, Chiari malformation, in which a part of the brain extends into the spinal canal due to an abnormality of the skull, premature births, which cause bleeding into the brain and disrupts the CSF flow, Dandy-Walker malformation, which is a rare condition characterized by agenesis of the cerebellum and cystic dilation of the fourth ventricle. Diagnosis of hydrocephalus is mainly based on clinical findings. Signs in infants suggestive of hydrocephalus include head enlargement, disjunction of sutures, dilation of scalp veins, increased spasticity, especially in lower limbs, tense fontanelles, and setting sun sign, characterized by retracted upper eyelids, downward deviation of ocular globes, and visible white sclera above the iris. In children and adults, look for the signs and symptoms we discussed above. Imaging studies include CT scanning to assess the size of the ventricles, MRI scanning to look for the presence of periaqueductal or cerebellar tumors and Chiari malformation. In infants, ultrasound scanning may show subependymal and interventricular hemorrhages. In most patients with hydrocephalus, surgical treatment is the preferred therapeutic option. Most patients eventually undergo shunt placements. Several different types of shunts are used. Ventriculoperitoneal shunts drain excess cerebrospinal fluid into the peritoneal cavity. Ventriculoatrial shunts drain excess CSF from the ventricles into the right atrium. Lumboperitoneal shunt is mainly used in communicating hydrocephalus, and it drains CSF from the lumbar subarachnoid space into the peritoneal cavity. Thorkildsen shunt is used rarely and only for acquired non-communicating hydrocephalus. In this method, CSF is drained from the lateral ventricles into the cisterna magna. Rapid onset hydrocephalus is a medical emergency and need to be corrected immediately. Treatment options include ventricular tapping in infants, open ventricular drainage in children and adults, and ventriculoperitoneal or ventriculoatrial shunt placement. Other treatment options for hydrocephalus include choroid plexotomy or choroid plexus coagulation to reduce CSF formation, opening of stenosed aqueducts, and endoscopic fenestration of the third ventricle.